In this video, we're going to explore how a professional tells if someone has OCD. So if you go in, how do you know you've got OCD? How would a practitioner be able to tell that you had OCD? So I'm Chris, I'm from the Leeds Anxiety Clinic. I've got my colleague Chris here as well.
Hello.
So Chris, what kind of things would you look for if someone came to you, they said, well, I think I've got OCD, but I don't really know? What kind of signs would you encourage them to look out for? What kind of things would you look out for as a practitioner?
Yeah, I think it's worth saying that there are a couple of evidence-based assessments for OCD, one of which the client can administer themselves. That's an OCDI, which is a 42-point Likert scale questionnaire about how impaired they are by certain behaviours, thoughts and feelings. It's not how much you do it, it's how much it distresses you. That's about 80% reliable. So it's going to get you nearly there. It's going to give you a good amount of information if you want to ask and answer those straightforward questions. There is a more rigorous extended interview that a psychologist would be qualified to carry out. Myself personally, I wouldn't be qualified to carry out that, so I would not give someone a diagnosis of OCD. That questionnaire, that extended interview would look more into not the manifestations of OCD, as in, do I have these intrusive thoughts? Am I engaging in this compulsive behavior? But it would be more the beliefs that I have about how my brain works, what thoughts mean, what's my responsibility, what does a good person look like, and when I'm presented with an uncertain situation, what do I feel I need to do with that uncertainty? So that extended interview is much more in detail and will give you a much more reliable diagnosis of OCD. The 42-point Likert scale, the OCD-I, is really just, do you look like your stereotypical OCD sufferer? Do you do some of the things, and do you think some of the things that you'd expect an OCD sufferer to look like? But again, it's a little bit like, I think I've said in another video, it's a little bit like saying, do you blush? Well, a lot of people who have social anxiety blush, therefore, if you blush, we think you have social anxiety. Whereas actually, there is a much better definition of what social anxiety is that involves, what do you believe, what do you do, what do you think your responsibilities are? Does that answer your question?
Are we saying here that maybe someone is watching this and thinking, well, I obsessively clean my bathroom, but we're saying, well, that's not necessarily OCD because that is a symptom, but OCD is something else higher up the chain?
Yeah, if you're cleaning your bathroom because you feel you have repeated intrusive thoughts that your bathroom contains germs, viruses, bacteria, it feels horrible that your bathroom has viruses, germs and bacteria, it feels really irresponsible that you would risk exposing your family to those harmful viruses, bacteria and germs, and you feel compelled as a morally good person to be 100% sure that your bathroom does not contain harmful germs, viruses and bacteria, otherwise you couldn't live with yourself. That sounds very much like someone who's obsessive compulsive. They'd be miserable and they'd be cleaning because it would be monstrous to not clean, because they can't tolerate even a 1% chance that their family might get sick from harmful bacteria, say. If I just happen to love the shine of a shiny white bathroom and I'm quite prim and proper and I always wear immaculate white shirts and I take impeccable care of myself, and some days I clean my bathroom twice because one of the kids has gone in and grubbed up the tub, and I don't have any of that distress or impairment associated, then I'm not imagining that that's OCD. That's just somebody who could probably rub off well on me and help me polish up my act a little bit and maybe keep a cleaner house.
Yeah, so someone like Monica from Friends, who loves cleaning but lives a normal life, indicator maybe not so much OCD, whereas
Yeah.
someone who's feels that real compulsion and just can't live without going and cleaning would be more along the lines of, well, this is what we're looking at as OCD now.
Yeah, and I mean, in brute terms, if you are cleaning your house twice a day, holding down a full-time job, or full-time care responsibilities, or you're studying or whatever, and you're meeting all of the goals of your life, but you just can't stand a dirty bathroom, and a couple of times a day you're spending 15 or 20 minutes cleaning it, that doesn't seem very distressing, and it doesn't seem like it's impaired. But if you're somebody who's disabled by the overwhelming time and distress that's being taken up by not being able to tolerate the bathroom potentially being unclean, and you find it is distressing and impairing, and you're not able to carry out your day-to-day activities, meet friends, leave the house, hold down work, hold down studies, take care of your caring responsibilities, if you're ignoring the kids because you just can't tolerate the idea that the bathroom might be unclean, so you've gone back upstairs for the second time this morning, that sounds much more distressing and much more in the realms of what we're talking about with OCD.
Yeah. And something like, for example, some people really like to say have their books on the bookcase. They want everything perfectly aligned so that all the books are just so. When does that become OCD? Where's the line there?
Well, you can have an obsessive-compulsive personality.
Yeah.
And if it's something that doesn't distress you and doesn't impair you and doesn't cause you difficulties, then I wouldn't, some people will refer to an obsessive-compulsive personality disorder. But unless it, again, is impairing you, and unless it is causing you distress, and unless you find it intolerable, I wouldn't use the D word to describe anybody if they're happy and they just have a personality trait that means they demand certain things. You could say that, the people who dress impeccably and always have to have ironed clothes and always have to have the shoes polished and whatever, or have to have things in a certain order, or have to have maybe every other step they can't step on the cracks or whatever it is. If it's not impairing them, and it's then, why do I need to concern myself with that?
Yeah, so you can be obsessive. That doesn't necessarily mean disorder. It's really, we're looking for how it's impacting your life to work out whether that's a disorder and something that maybe would benefit from treatment.
Yeah.
So if we've got, someone might come in, they might be unsure, they think, I'm not sure if I've got OCD, I'm not sure if I've got anxiety, I've got these feelings, but I can't really make sense of them. How would we differentiate? Do we need to differentiate? What kind of indicators would suggest anxiety or OCD?
Yeah, well, I have a very honest conversation with some of the clients I work with along the lines of, I'm not a psychologist, I'm not there to diagnose, and in actual fact, if someone comes to me and says, I'm obsessive and I'm compulsive and it's causing me a lot of distress, we can help them be less obsessive and compulsive, and we can help them reduce their distress without the need to pigeonhole them and be 100% certain that they have this, in the Diagnostic and Statistical Manual, page 67, do you meet 5 of these 7 criteria? I don't need to do that. If somebody comes to me and says they're distressed by thoughts, feelings and behaviours, and they don't like it and they want to change it, we can change it without having to be certain that we've called it the correct name and labelled it. So, for example, one of the things that people will often get misdiagnosed with, which is another reason why I don't go out of my way to diagnose, because you can meet the criteria for a disorder today. 6 months ago, you wouldn't have met the criteria. 6 months from now, you might not meet the criteria. If you're not distressed right now, then you won't meet the criteria for a disorder, even if you're experiencing a lot of delays and problems and obsessions and compulsions. So I tend not to get too caught up in the diagnosis, but one of the things that people will often be misdiagnosed is they will have generalized anxiety disorder and obsessive-compulsive disorder can often look very similar. So I work with clients who might have worries about their health, or I work with clients who might have worries about their body, or I work with clients who might have worries about a range of things. They might feel quite obsessively perfectionist. They might worry that they're not working hard enough, or that they're not, a good enough partner, or a good. We're complicated beings, and we can have worries about a range of things. And the key ingredient in generalized anxiety and obsessive compulsiveness is that rather than trying to engage with the individual worries or intrusive thoughts, if you will, and trying to use evidence to show that they're not true, both with generalized anxiety and with obsessive compulsions, you encourage the client to not problem solve the problem, and in fact see the problem as being the type of brain that they have that generates these problems, rather than whether the intrusive thought or the worry is actually true. So one of the reasons why I can be a bit blasé, I hope this doesn't sound too casual, but one of the reasons why I can be a bit blasé about knowing whether I'm dealing with generalized anxiety or knowing whether I'm dealing with OCD is, if you look at what we're actually going to do in terms of recognizing what the problem is and recognizing what the new behavior in response to that problem is, whether you label it a worry and you ask the client and encourage them to become mindful and not engage in problem solving, or whether you call it an intrusive thought and you ask the client to not engage in the compulsion of rumination, for example, you're actually doing the same thing. You're reframing the problem and not engaging with compulsive problem solving. So without being blasé about my colleagues who are eminently more qualified and can diagnose, I can help people feel significantly better and live much better lives, even if I don't say with 100% certainty I've got the right letters for what's going on. You can practice not treating your problems like they need to be solved without having to have necessarily the correct label.
Yeah. So, what we're saying is, I guess, if you're thinking, maybe I have OCD, I don't know, but I'm struggling, I'm in distress, it doesn't 100% matter that you get a diagnosis. What matters is that you do something about that distress.
Yeah, what matters is that you recognize the pattern of being distressed frequently by the same problem is a pattern that you can change. And you can change it by recognizing that in the past, it has not helped you to solve that problem. Now, that's the same whether it's worrying in the case of generalized anxiety, or it's the case of doing compulsions in the case of obsessive compulsive disorder. If you have a track record, if you're bright and you know your history, personal history that is, and you can see that worrying has not kept you safer or engaging with compulsions has not fixed the problem, then I think in both instances, two smart, rational people who come together, client and therapist, can agree that that's not working. And you can experiment with what the evidence shows is a better way of doing it, whether it's generalized anxiety or OCD, which is recognizing there is no value in becoming 100% certain that your thought isn't true.
Yeah, so if someone suspects they've got OCD, what would be a good first step for them? Where should they go? Should they speak to their doctor? Should they look online? Should they contact a therapist?
It's a very personal and private question, so I wouldn't wish to give advice as to what people should do, but here are their options. The path of least resistance is you can do an online OCDI, which is about 80% reliable, and it will ask you a bunch of questions to say, do you look like an obsessive compulsive? If you're getting distressed by these types of things and you're experiencing these types of compulsions, it'll get you 80% of the way there. could pay, or in fact, I'm not 100% sure what the waiting list looks like for the NHS, but you could go on the waiting list to see an NHS psychologist who could carry out that extended interview, where they can much more reliably tell you that your style of thinking is consistent with somebody who has OCD, and they can in fact give you a diagnosis which you can then put on your medical records, your GP. If you have private medical insurance, it means you can access certain types of therapies off the back of that diagnosis. I'm not going to get into in this video the benefits of having a diagnosis, but for some people it can be a really useful thing to have. What else? What haven't I answered? I feel like that was a long answer.
Yeah, we've talked through a couple of options there. If someone does engage with a healthcare provider or a therapist, what are they likely to get when they do that? What kind of things will happen? What kind of options are available?
Okay, yeah. So the therapy for OCD looks very much like, firstly, understanding what OCD is. I would say that in the case of, again, I'm referring back to generalized anxiety as well. In the case of generalized anxiety and in the case of OCD, the client believes that it is the right thing to do for them to become sure that the worry or intrusive thought they are having is not true. They want to problem solve to a degree of certainty that their thoughts are untrue and that they're actually safe. So they'll have a distressing thought along the lines of, what if my bathroom's not clean? I think we used in an earlier example. What if my bathroom's not clean? What if there are microbes or bacteria or viruses and they are going to hurt my family or, poison my guests or whatever? That's an intrusive thought. It does not come from anything to do with the real world. It does not come from how clean your bathroom is. It does not come from history, memory, or in fact, it's not telling you anything useful or true about the world. That intrusive thought comes from the fact that your brain's unconscious, all of our unconsciouses, have a feedback loop where occasionally it's useful for any mammal, big hairy mammals that we are, it's useful for any mammal to ask itself, how might I be threatened? And in the case of obsessives, that is going to be some version of their values being violated or them being threatened somehow.
And so how obvious do you think those thoughts might be? Like maybe someone's at home and they're cleaning their bathroom twice a day. Are they necessarily thinking, oh, it's because there might be germs and my family might be hurt? Or are they more likely to just have a feeling that they really need to clean it, and that's something that as they explore what's going on, they'll then uncover?
Yeah, you've got to ask yourself, how distressing is it to not do the thing? Some of my friends joke with me because I'm still, even though it's 2022 and we've all got modern fabrics and 30-degree washing machines, I'm a caveman who still irons. I like to iron things. I like to iron my trousers and whatever. And I've got various family members who've never used an iron in their life. The fact is, if I didn't iron, I'd suffer some mild discomfort about not going out in ironed clothes. I'm clearly not obsessive about ironing. I do it because I like it. If you asked me to not do it, would I be getting intrusive thoughts that I'm a monster and I'm embarrassing my friends and I look like a person who doesn't take care of himself? Would I feel morally that I was a slovenly, dirty person who would I be really distressed if I didn't use the iron? No. I'm clearly not obsessive about ironing. But what would the distress look like if that person was to not clean their bathroom? Would it be a question of, I've won, I'm doing well in life, I'm well paid, or I'm well resourced, or and I can afford to have lots of free time? And you know what? One of the things I like to do in my free time is clean my bathroom. I really like it. I get a good feeling afterwards. Then that doesn't look like a problem. But if they were to not be able to clean their bathroom because the kids were poorly or they had other responsibilities within the home, And they were very, very, very intruded upon by the thought that, oh my God, my bathroom, there's going to be bacteria growing, it's going to be disgusting. What if one of the kids needs to go and use the loo? The toilet bowl's going to be harbouring, and it's very, very distressing that their bathroom might be contaminated and their kids might be sick as a result. That's an intrusive thought. That's where we're talking about today.
Yeah. Great. So we talked about the first part of what a therapeutic process might look like, which is understanding what's going on. What would happen after that?
Yeah, so that's actually half the battle in terms of understanding that you don't have a bathroom problem, you have an obsessive brain. The problem is not that your bathroom might be harbouring all these germs. Our bathrooms, we've got up today and we've come to work. I know you well enough. I'm assuming you were not cleaning the bathroom at 7:15 this morning.
I was not.
I certainly wasn't. It's possible that some urine was left around the bowl. It might have multiplied overnight. I might not have cleaned it away this morning. There might now be some germs multiplying as we speak in my toilet bowl. I've not thought about that today. I don't have the type of brain or the particular worry, let's be blunt, your OCD can manifest itself in lots of different ways.
Yeah.
But I don't have a type of brain that frequently asks me throughout the day, how might I be threatened? And how can I be sure that that threat's not going to come true in a forceful, sticky, aggressive way that an obsessive has. So I have faced problems throughout my day to day, and each of the problems has presented itself and I've overcome that problem. I've remained roughly on task throughout most of the day and solved what's in front of me. I haven't got a pet, that's a bit disrespectful because that implies it's not serious, but I haven't got a pet obsession that has followed me to work and has been bashing away at me all day. What if? We talked in another video about checking and, sort of have I locked the door. I'm at best 95% sure I have locked the door, not 100%. I'm at best sure that, I don't have a germ problem in my toilet, but I'm 95% sure of that? I don't know. I'm certainly not 100% sure. I don't have the kind of brain that keeps on the same topic, banging away. What if what if one of the kids goes in the bathroom? What if one of the kids drops a toy into the toilet bowl and then reaches in and it's all that germs? What if? I don't have that type of brain that keeps asking me those obsessive type questions. So understanding that the client does not have a toilet problem or a bathroom problem, but this is a much, much more personal manifestation of the way their brain works, how they think, can help them understand. And one of the things we look at is personal history. I've never met anybody who's only ever had contamination OCD about their bathroom, and then when I've gone through their personal history, found no previous manifestation of obsessions or compulsions.
Yeah.
There's always going to be some clues that this will have manifested itself in more than one way at some point, even if it was quite mild. So that's one of the things that a therapist might look for in terms of helping the client see they don't have a bathroom problem, they have a way that their brain processes uncertainty and threat problem. And from there, we can start to reframe the problem by helping them to see that the solution to that is not contained within cleaning the bathroom. The solution to that is contained within reframing how they see their thoughts. Their thoughts are not telling them anything useful about the world. So rather than treating the thought that I might have a dirty bathroom and therefore my solution is to clean the bathroom, If I start reframing the problem as I might have a dirty bathroom, there's another manifestation of that brain process where I keep asking questions and demand certainty that that thought's not true. Then I can start to we do something called a theory A, theory B, which is we look at the world as though I had a bathroom problem. And then we look at the world as though, what if I've got a fear of having a dirty bathroom problem? One is the problem is within the bathroom. The other is the problem resides within my beliefs about why I have the thoughts that I have. And so we reframe that problem, and then we practice not engaging in the compulsion, which is a form of behavior designed to make me 100% sure my intrusive thought wasn't true, and instead practice not engaging with the intrusive thought as though it were important or in fact a problem that needed to be solved.
Yeah, so we'll understand and challenge some of the set ways of thinking that someone is going through, and then we'll use that to do something different, and that's what will bring about the therapeutic change.
Yeah, and the really unusual, interesting, and frankly, I never forget how backward this feels to most people the first time they hear it. We will not challenge the belief that their bathroom is dirty. We will not try and prove to them that their bathroom is clean. We will not engage with that as though we needed to remove the uncertainty. Actually, rumination, which is probably one of the most common forms of compulsion that certainly a lot of the clients I meet are engaging in, is the need to remove the uncertainty that their bathroom might be unclean by trying to decide whether their bathroom is unclean or not.
Yeah.
In other words, well, I cleaned it yesterday. Have any of the kids ever got sick? And it actually looks like what you'd expect a therapist to do. These are bright people.
Yeah.
I work with doctors, I work with lawyers, I work with accountants, company directors, scientists, researchers. OCD is overrepresented within medical professionals. These are bright people. These are problem-solving people who are using their best problem-solving to try to become certain that that intrusive thought is not true by ruminating.
Yeah.
And actually, one of the things that is most surprising when we work with clients is that they do not need to become certain that that intrusive thought isn't true. What they actually want to become is practiced at recognizing I've got an obsessive brain. It frequently generates very unpleasant intrusive thoughts. My job is to recognize that that's an intrusive thought and then not need to become certain whether it's true or not, and practice not engaging with it.
Yeah. So people might be thinking, well, you've used cleaning in this, that's a really common one, but I have this really weird thing, or maybe an embarrassing thing, a shameful thing. If it's not the kind of generic, did I lock the door, I need to clean the house, I need to check the gas, how does someone know, what other kind of things might people run into with OCD?
Yeah, it's a really good question. I work in private practice. Obviously, the work that I do is confidential. Often clients will come to me and they're very, very interested in confidentiality. Does my GP need to know? Because they are experiencing intrusive thoughts which violate their values. So in some cases, it will be, am I harmful somehow, or am I threatened somehow? It might be, when I went out at the weekend, did I kiss somebody that's not my partner? I had some alcohol. I had a whole 8-hour evening out. I can't remember all of it. What if during one of those periods that I can't remember, I bumped into somebody and I kissed them or whatever? There's a moral element to a lot of intrusive thoughts, which is, what if I'm morally somehow a bad person who has violated my own values? A less shameful version of that might be, did I hit someone with my car when I was driving home tonight? Clearly it violates my values. I don't like hitting people with my car. I have a lot of love for cyclists. Hello, everyone. But so it would clearly violate my values if I hit someone with my car. But it's not did I hit someone with my car? It's did I then selfishly drive off because I didn't realize I'd hit someone with my car. If I hit someone with my car and they go, ouch, and I call them an ambulance and whatever, that's not a violation of my values.
Yeah.
It's did I hit somebody, either not realize that I'd done it, in which case I'm an incompetent monster and I drove off, or did I actually recognize that I'd done it, get so frightened that I drove off, but now I can't remember, because you can't remember not doing something. If you said to me, did I see a dog on the way to work this morning? Did I see someone walking a dog? First thing that's going to go into my mind is, well, I'm picturing someone walking a dog. Did I see someone walking a dog this morning, or has that just come from memory? I don't know. I can't tell you that I didn't. So it can be very, very difficult for people to know that they didn't do something wrong because they can't remember.
Yeah.
Some other examples. I guess it's useful in case someone's watching this and they're harbouring a particularly worrying, intrusive thought that they fear might be true. I suppose one of the more challenging in our cultural context is, you might get somebody who's watching a nappy advert and there's two gorgeous little kids, frolicking around on the TV or whatever, and they're lovely. We all have that instinct to just find little babies gorgeous and whatever else, but they might have the thought, what if I'm sexually attracted to those children? I'm feeling an emotion when I see these lovely little babies, cheerful on the TV.
Yeah.
I like what I'm watching. What if that's a sexual liking? What if I'm a paedophile? What if I actually fancy kids? And the minute one of these intrusive thoughts occurs, the poor person who has that intrusive thought mislabels it, not as being, I've got an unconscious that's constantly asking the question because I've got an obsessive brain. What if I'm somehow threatened or threatening? What if I violate my values somehow? What if I get ostracized from my tribe, where all my security and my belonging and safety and well-being comes from? What if I somehow violate the rules of my culture so that I become isolated and ostracized, lonely and very unwell? So it can be, what if I'm attracted to children? What if I've harmed someone? What if I ran somebody over with my car? What if I might be walking down the street, I might be a real animal lover, and I get the intrusive thought, what if I drop kick that cat into the road and it gets killed by a lorry? It can be horrible, can't it? It's literally whatever would violate your values. I can have the intrusive thought, what if I am that thing?
Yeah, so a lot of the time people might be maybe suspecting they've got OCD, they're having these really uncomfortable thoughts, and they're thinking, well, I can't go to a professional and tell them I'm having that thought because that's horrendous. But actually what we're saying is, whatever you come in and tell us, you're not going to shock us because that's just
absolutely
the bread and butter. This is the kind of thing we deal with every day.
Yeah, I've worked with absolutely happily married, lovely people who adore their partners, and their biggest fear is, what if I get up in the night and get a knife and harm my partner? Or parents. I mean, the most overpowering virtuous instinct is to protect our offspring. And yet I've had parents who've talked to me about, what if what if I put my kid's head under the water in the bath, or what if I put a pillow over my baby's face, or whatever. I apologise, maybe we should put a warning on the front of this, that I know this is really unpleasant, distressing things to talk about, but if you can imagine it, then you can have an intrusive thought about it. We could literally go out into the street now, and if we could get people to answer honestly, if you said to them, if you were to have a thought that was so upsetting that you might be a bad person somehow, what kinds of things might you imagine yourself doing in that horrible thought? And then you could just make a list of, and that would be your list of intrusive thoughts. It's exactly because it's the worst thing we can imagine and we fear being it the most that makes it an intrusive thought. And of course, the therapy is all about helping the client recognize it's because their imagination knows that would be the worst thing that they're having that intrusive thought. What if that comes true? What if that's true? What if I'm that thing?
Yeah, so it's a reflection of them being a good person and caring and worrying about these things. And I think it can be very uncomfortable to talk about, but also in many ways it's important for us as a society to talk about these things, because in terms of demystifying and bringing mental health more into the mainstream, one of the reasons these things weren't talked about is because these things are very uncomfortable to talk about. And so hopefully by us talking about it in this video, by you talking to people at home, talking to their friends and family more about these things and normalizing these things, then a whole lot of people suffering right now will be more amenable to getting help.
Absolutely.
Because these things really are normal. You're not some kind of freak if you're having these thoughts. It's OCD.
Yeah, you've 1.4 million people in the UK experiencing intrusive thoughts. It is true to say that a big chunk of those will be the stereotypical checking the gas, checking the door, checking cleaning. But a sizable 500,000 or so of those people will be having some really unpleasant intrusive thoughts. And we don't want to stereotype cleaning, checking gas, locks as being what OCD is. We really want to let people know that it's anything that violates your values can be grounds for an intrusive thought.
Yeah. Okay, wonderful. So in this video, we talked a bit about what we would look for as practitioners in terms of OCD. And I guess what we came to the conclusion is that having that label, that diagnosis, isn't as important as how much is someone struggling, how much are they in distress at the moment. And then we've talked about some of the things that a typical OCD person might be struggling with as well. But really, if you're sitting at home and you're thinking, well, I'm not really sure if I have OCD or not, but I'm in distress, then that's probably a good sign that you should seek help, whether that's your GP, whether that's a specialist therapy service like Leeds Anxiety Clinic, whether that's a support group, a book, whatever that is. That should really be your guiding principle as to whether you should proceed, because these things are treatable, right?
The outcome is very good. It's not possible to make intrusive thoughts stop. I hate to be the bearer of bad news, but it's possible to radically change your relationship with what you think those intrusive thoughts mean and what you think you need to do about it. It's possible to have an intrusive thought and say, well, there's no surprise. I know I've got an obsessive brain. I know I have these intrusive thoughts. That's literally the worst thing that I can imagine happening. That's why my brain's thinking it. And the good news is I don't need to do anything about it.
And what that will give you is your life back. If you're really impacting your quality of life, that's the thing that we can fix.
Yeah.
Great. So hopefully you found this useful. If so, please give this video a thumbs up. And if you want to learn more about anxiety and OCD, then hit that subscribe button, because that's what our channel is all about. And we'd love to see you in another video.